Board bombs.
Welcome back.
Hold on. I'm swollen. A little struggle there, a little post-Thanksgiving struggle. Welcome back to EM Board Bombs.
Happy to have you.
Happy to have you. Hey, we're not going to do the whole, what we do, because, again, if people don't know what we do, they should probably just find another podcast at this point.
Yeah, for real.
Yeah, I think we're big enough now.
Big enough. We made it.
We made it. We made it. Yeah. Hey, Briggs, how was your Thanksgiving?
It was lovely. Had to work most of the day, but got off in time and rushed to the house and had wonderful food. Very thankful.
Ah, that's nice. That's
Very
nice.
grateful.
Did Mama Briggs whip up some good stuff?
Yes.
Awesome.
Yes, the whole family was there.
That is great. My son still talks about Mama Briggs chicken that she made when he came. Yeah. He came to visit. It's good times. Good deal. Good deal. Hey, we're just gonna jump right into this topic. It's Thanksgiving themed. All right, so let's get into it. I hope people appreciate that we're rocking out doing this on our Thanksgiving break, which isn't really a break, but we're just doing it. I just want some appreciation. I hope there's a little bit of background applause or appreciation.
I hope the specialist out there is thanking us for our service. Yeah.
Oh, don't get me started. So
thanks for not calling me.
the title of this episode is The Great Stuffing Choke, Managing Holiday Aspiration and Airway Obstruction.
That's epic.
Epic. Hey, a 3-year-old boy presents to the ED with the chief complaint of suddenly not talking and difficulty breathing while he was eating his Thanksgiving dinner. He is cyanotic, drooling, and unable to speak. So immediately, every single person listening to this is like, oh, please don't ever give me this patient. On examination, he has inspiratory stridor and reduced air movement on auscultation. A lateral neck x-ray shows no radio-opaque foreign body, but there is mild subglottic swelling. So what is the most appropriate next step in management here? Is it A, perform back blows and chest thrusts, B, administer nebulized racemic epinephrine, C, perform emergent flexible bronchoscopy under sedation, or D, attempt direct laryngoscopy for foreign body removal? Briggs, before you get into that correct answer, boards, they ended recently. I know
for some
there's a lot of, unfortunately there was a lot of consternation with some of the results that came out that ABEM published. It was a bit disappointing. Shout out to the people, who passed, but also shout out to the folks who did not pass. I think it was one of the lowest pass rates, or if not the lowest.
Modern emergency medicine.
Yeah, and we'll get into that at the end of this podcast. So make sure you listen to the end, and we'll get into that. So again, we're not going to plug the EM rapid bombs or anything like that right now. We'll just talk about some of the stuff that folks can do who did not pass boards. And we'll refer to the premium pod later, but we do have to give a shout out to EM News. Is while they're our only sponsor. Remember, we do not take any other sponsorship. So please, folks, stop reaching out to us. I don't think people listen to this part when they reach out to try to get us to sponsor. And
we get emails every week.
I'm sorry, we're just we don't take sponsorships for devices and other stuff. That is that's not us.
We're just not interested.
Doesn't matter. We we're gonna say no. Don't care what you're gonna throw at us. We are supported by EM News and also our premium subscribers as well. So thank you for the support. Hey, Briggs, get into the answer.
Yeah. So correct answer here is going to be attempt direct laryngoscopy for foreign body removal. You could also do video. We just didn't give that as an option, but yes, laryngoscopy for foreign body removal. So Thanksgiving dinner, a time of family and food, and unfortunately the occasional emergency.
Yes.
Most of the time your emergencies are going to be GI related. Now I did have a food impaction on my Thanksgiving
No way,
shift.
Did you really?
Not personally, but the patient did, yes.
Oh, okay. Thank you for clarifying that.
Yes. And shockingly enough, my gastrointestinal specialist colleague was extremely nice. I thought this was going to be kind of tough to get them into the hospital. And to their credit, if you are listening, Doctor at said hospital for GI coverage,
right,
much appreciated.
Without
hesitation, came in and took care of it.
Looking forward to the excuse to get out as well. So you should have
That's
asked.
right. They were like looking at their phone.
Certain family members were maybe present, and they were like, "Gotta go."
Oh, that's hilarious. I didn't think of it that way, but very nice to come in and do it. Anyway, hey, so we're diving into a classic holiday crisis, which is airway obstruction in a pediatric patient.
Yep.
And what do you do, besides panic, when a child begins choking on a piece of turkey you're stepping? So let's talk about the steps you need to save this patient's life, and we'll throw this challenging multiple choice question. We'll talk about the explanations of the answer choices later, because I'm sure a lot of people were leaning towards choice A, which was the back blows and chest thrust. We'll talk about why that wasn't the right answer. Hey, the number one question you should be asking yourself when a child comes in and you're concerned about choking or concerned about something, upper airway obstruction in general, what's the number one question you should be asking? Is
the child moving any air?
Perfect. That's exactly right.
Yeah. So, and really it's three things here that we're going to talk about. Is it a complete obstruction? So remember, complete obstruction is going to be, there's no cough, there's no sounds at all, there's cyanosis, and there's panic, and rightfully so. It's going to require those immediate interventions. Like that's where you're doing back blows, chest thrusts, or the Heimlich maneuver, right? Based on obviously the child's age and size and all that. Now, partial obstruction is what we were talking about here. So that's where you have stridor, drooling, or coughing, but you're having some air movement. And the hardest part here is keeping that child calm when you're trying to figure out more definitive interventions, right? And then
you should not be doing that.
And so this is the third thing that we want to talk about. And again, you're not doing this. You're just not. Avoid blind sweeps, especially in a situation like this, and that can really push the foreign body down into the airway.
I'm doing the blind sweep maneuver.
Yeah,
just say no.
Just say no. Dare.
The Nancy Reagan. Yeah.
Oh, gosh.
Nancy Reagan on the screen here.
The thing that actually got people to smoke more, right? But anyway, right.
I still remember going to ASEP one year, and Amal Mattu had a PowerPoint, and he had like a drugs not to give in certain cases, and he had the Nancy Reagan like picture right there. So just say no.
And hashtag shout out to Amal. He was a great guy. He's been on our podcast before. We're big fans. He's a fan too. He's great.
Awesome.
He's great. Shout out. Hey, so avoid those blind sweeps, right? And okay, so we've established that. Now talk about this.
We have established that.
Hey, we've established. Enough. I know people right now are just like, can you guys just move on? We got it.
Yeah. So can you please? We got to hurry. I still got the in-laws in town.
Right. I'm listening to you at 3x right now. So why is stridor important?
So stridor is probably the most important thing you could ever listen for on your stethoscope. It's like the one time your stethoscope could change management. It's basically it indicates.
It's not true. Okay,
just
all
joking,
the med students, in particular, listening to this, don't listen to that. Your stethoscope is a very important thing.
There's a reason he's laughing, folks. He agrees. He secretly agrees.
Go.
Yeah, he's an academic attending. He doesn't even carry a stethoscope.
Stop it.
So stridor indicates partial airway obstruction in the upper airway. It's most often at the level of the larynx. And so when you put your stethoscope here, and it's gonna, if you're looking on the YouTubes, you can see us. It's gonna be right below that Adam's apple, kind of right where the beginning of the neck starts, basically. So there's two types of stridor here, and we're promised we're not getting intense here, but this is just important to know in pediatrics because of that upper airway difficulty of swallowing that can happen in certain pathologies. Essentially, inspiratory stridor, when this child is trying to take a deep breath in, you hear stridor. That suggests some type of supraglottic obstruction, like a foreign body. Now, biphasic stridor, meaning inspiratory, expiratory stridor, could suggest like croup or a deeper foreign body. Foreign body's migrated deeper into the larynx or into the trachea. So in general, any type of inspiratory stridor, you should be worried about foreign body right above the larynx.
Supraglottic.
Yeah. And it's so important here because when you hear stridor and the child's struggling to breathe, you know that is an upper airway issue versus, wheezing or like Rales, whatever, or decreased breath sounds. That's all different. That's like that asthma or active airway stuff. That's completely different. So let's dive into the next thing, which is, okay, you have a child struggling there and you're thinking to yourself, I need to take a look. I need to, whatever this is in there, I need to take a look and pull it out potentially. You know that step, but how do you get to that? Because obviously that child is not going to, one, tolerate that. Two, you want to comfortably have the child in a position where you're not taking away their efforts to breathe, right, and oxygenate. And this is a difficult scenario you're in, and it's a scary scenario if you don't have the staff. But if you're at first of all, if you're at a major health center, of course, call for backup. If you have backup, go ahead and call anesthesia, ENT, whatever. It's always good to have them at bedside, especially if you're dealing with a young child. If you're at a community center, you're on your own, YOLO. So
yeah. And even then, I'd
you're
say
on your
if you're
own,
at
and our hats are off to do.
Yeah, but even if you're at a community center, usually
Yes.
there's anesthesia on call or someone, right?
Not on Thanksgiving. But
yeah, fair, fair. But yeah, this is where you're not
Yeah.
cowboying it at all.
No, you should have backup.
Yeah, you should definitely, anyone that can potentially help. You either calling them in or you let them know what's going on, especially if you've got some brief moments here. Hey, get into some of the sedation tips and tricks
so the goal here is you want to obviously provide adequate sedation, but you want the child to be breathing on their own, obviously. And this is a very, very tough balancing act of, moderate sedation, but not going to that razor edge of they fall off and they no longer spontaneously ventilating.
Right.
And so if the child's maintaining some type of airway exchange and the sedation risks, worsening the obstruction, you're concerned about that, don't sedate and wait for help. But in these rare cases, you're going to keep the child upright. It's kind of like those epiglottis cases where you're going to optimize the airflow, call anesthesia, take the child to the OR, and that's it. Hopefully, anesthesia or ENT will come downstairs and look at the patient and say, oh, yeah, that patient's going to the OR with us. Like they just take one look at him and they're like, no one's going to lay that child down to sedate or do something if they're up in the tripod position, they're struggling to breathe. Versus, in certain cases where you feel like, hey, I got to act right now, they're cyanotic or I don't have time to wait to the OR. It's a complete obstruction, et cetera. Then you can take a look. And in those cases, complete obstruction, they may be unresponsive. You may not even have to sedate. But it's just it's really difficult to explain when you should or when you shouldn't sedate. It won't be ever tested for sure. The question is if the child is in a tripod position, they are comfortable where they're at and they're struggling to breathe, you optimize their breathing and you call for help and go to the OR. That's easy. Same as epiglottitis. But if you have a patient that you have to act right then and there, you're going to have to sedate. And of course, you're going to do the usual stuff. You're going to, I know. You can cowboy up, pre-oxygenate with high flow oxygen. You're going to, assess the risk of complete obstruction. We talked about this. If it's a partial obstruction, you'll be very cautious because sedation could worsen the obstruction or, relax those airway muscles and something could just fall right into the larynx or trachea. And then, of course, you're going to perform those airway maneuvers with your team ready. If you have ENT anesthesia there to help you out, that's great. Sometimes you got to act without them. We get it. We understand. Sure, you have all your equipment. Go through the usual setup of intubating. Got it. And your sedation options, we all know this stuff. Obviously, our first line option for these, for any pediatric patient, sedation is ketamine. This is preserving airway reflex. This is such a great
This is probably
medication.
like the most important thing here.
Absolutely.
You're using ketamine. Anything you can to preserve the child's own airway drive.
Right. And the dose, 1 to 2 mg per kg IV or 4 to 5 mg per kg IM. And IM is completely safe if you're in a bind and you're stuck and your nurses are, you're at a hospital that doesn't do IVs typically on children. You can totally get away with IM in that situation, in a complete emergent, horrible situation. Propofol is fine too, but again, I would stay away from that. I would stick with ketamine, and that's what your drug should be. No one has an allergy to ketamine.
I will tell you with ketamine, it's if you get a laryngospasm with ketamine.
Oh my god! You're in trouble.
At that point, you're just like, why God?
That should be an oral boards case we do for each other. Great, awesome. Okay, cool. And so the key steps here is you sedate with ketamine, and then you're going to take a look, and you're going to grab your McGill forceps. You're going to grab your VL or DL laryngoscopy. We prefer VL here, video. The evidence shows that it's superior in terms of views and success rate of intubation. But in this case, you're just looking, have what you have, of course, but we prefer video as your first look. And what you're doing here is you're visualizing the foreign body. Hopefully you have some McGills or any type of like forceps at bedside. You can reach in there and then pull that out as quickly as possible. You can use a curved or straight blade based on the preference. You're not technically intubating here, so depending on the child's age, a Miller may be what you have for the pediatric patient. But if you're more comfortable with handling a Macintosh blade and you're not intubating here, you're just looking, that's fine. The whole point is you're just trying to look for a foreign body here and retrieving it. Now, what happens if that fails? I'm going to let you get into this. What happens if you are unsuccessful? And this is this actually hits home. I had a very similar case to this in an adult that unfortunately choked on some steak at one point in my career and came into the ED, and the resident took a look with the blade with some McGills, couldn't see the food at all. The patient was at that point not breathing at all, And so we tried to intubate, and then the ETT wouldn't pass through because whatever food was right below the cords. And then you'll see kind of what do you think happened next in this case in terms of getting an airway.
Oh gosh.
Yeah. They were an adult, so it was a little bit less, what's the word? A little bit less sweating going on.
What was it? What was it?
Piece of steak.
Oh, of course.
Yeah, of course it was.
Yeah,
a piece of steak.
Always like a piece of steak.
Yeah. Anyway, so in that case, you'll see what happens next. We'll hint at what we had to do. But if you don't see the foreign body, or you can't pass the instrument through the airway, you can't do it, and they are cyanotic, hypoxic, whatever. In that case, if you haven't switched to VL, you should.
Yeah.
But
I mean, honestly, you should be a VL. But, that, I feel like that's like, airway management 101, that you should be optimizing everything, right? So if no airflow or visualization is possible, look, you're just at that point, you're going to be having your crike tray ready. You move to a surgical airway. So remember, crike is rarely done in children who are under 12 due to the anatomy, right? This is where you're doing needle cricothyroidotomy. And that's where it's preferred. This is where ideally you're having ENT or anesthesia with you at this point already, or even a surgical team with you, right? You're having everyone, all hands on deck with you when that's the case. And that's just a tough case.
For sure.
So you guys ended up criking?
Yeah, we did. So if you do have that subglottic, foreign body, you can't see, can't pull it out, it's below the cords. You, at that case, go ahead and just try to shove an ETT down and just at least try to ventilate and get them on a ventilator. Fully sedate them, at least try to oxygenate. If you're unsuccessful doing that too, then that is absolutely when you would try to do a surgical airway. But very unfortunate case. Of course, you're never going to be tested on this. The only thing going to be tested on is the initial steps, which is, complete or partial obstruction. When are you going to the OR, or when are you dealing with this here in the emergency department? That is really the defining characteristics of what you could be asked about. And speaking of those answer choices, let me go over those. Choice A was perform back blows and chest thrusts. This is only appropriate for complete obstruction.
Right.
And that means there's no airflow. The child is cyanotic. They will die unless you do something immediately to try to push that out of the way as quick as possible. And the child in this question here, we had the child that was cyanotic but had stridor, suggesting that there's some airflow present and it's a partial obstruction. That's a different situation to deal with. If you do back blows or Heimlich, you could maneuver that foreign body deeper into a complete obstruction. That would be bad.
And remember, a part of this, right? So we determined here that this is partial, and you're not doing what? What are you not doing?
Back blows and chest thrusts,
and one other thing, you're not doing a blind sweep, right?
Of course. No blind sweeps. Choice B was talking about administering nebulized racemic epi. Not the answer here. That's for conditions like croup or maybe even angioedema in children. Causes airway swelling. The story here doesn't fit that. This was sudden onset, eating dinner. This is so classic for a foreign body. Racemic epi is not going to help. Performing an emergent flexible bronch under sedation, that's wonderful. And in theory, and in the textbooks, it says that is the next step. But that is wonderful if you, 1, have the equipment, 2, have the staff, and 3, have a controlled OR environment. That is an OR environment step. You are not whipping out the bronch under sedation for a controlled foreign body removal. In this case, you are dealing with a disaster situation. And then choice D, of course, correct answer, attempting video or direct laryngoscopy. That's first-line intervention for any suspected supraglottic obstruction.
Right. And look,
and
you're getting ready for all your airway stuff here, but you are having multiple tools ready to retrieve a foreign body. So whatever you've got, you are literally busting it out to see what you can do to remove that foreign body. So hey, let's get into some of the pearls. So we're just going to we're going to wrap this up. Let's wrap it up.
Go through it.
Yeah,
appetizers
and
main course.
Dave Chappelle, remember that wrap it up box?
Yeah. Do the James Harden, the soup.
The soup. Let's wrap it up. All right. So initial steps. Always assess the severity of airway obstruction. If the child is going to be conscious, if they're moving air, you're going to be avoiding some of those invasive interventions until it's necessary, right? And then laryngoscopy, direct laryngoscopy is obviously it's a life-saving skill. It's going to, you're going to be doing that to retrieve an upper airway foreign body. So plan B, if laryngoscopy is unsuccessful, what are we doing here?
Surgical airway.
Yeah, it is what it is. And lastly, prevention reminder, just during the holiday season, remind parents to closely supervise their children. It's a quick PSA from us, especially while eating foods like turkey, grapes, nuts, which are common choking hazard. The more you know.
We're like the ad council.
Yeah, it's like that
Yeah.
old NBC commercial, the more
Pass
you
it
know.
on.
You know?
Those billboards.
Yeah, I know, right? Oh man. So look, it's airway obstructions just are terrifying. That's why we didn't come up with the funny stem or anything like that.
No.
There's no joking around about stuff like this. You need to be confident, and especially with your staff, because look, a 3-year-old kid struggling. There's a lot of panic going on. You need to make sure you're controlling the room here and being the person who's the most calm in a situation that is very unnerving. And just remember, stridor is going to be your clue to an upper airway issue, and laryngoscopy is going to be your best tool in a foreign body emergency, especially when it's a partial obstruction. Hey, Briggs, let's talk
Perfect.
about the kind of elephant in the room. Well, not really the elephant.
That's
I
kind
mean,
of awkward.
I don't even know. Yeah,
Yeah.
I know a lot of our, we've been getting some emails and things like that from folks who listen to our main pod here. And just, I think there's been a lot of consternation on Twitter and other things about folks who unfortunately didn't pass the boards. We haven't really had much time to process or see how we can help. I mean, obviously, look, we want to tell folks that we have had multiple subscribers or people who subscribed to the podcast who didn't pass boards before. They subscribed and they were able to pass. I don't know if our podcast helped them, Briggs, but I would say, I think, look, use other resources that are available. It doesn't necessarily have to be just a question bank. Maybe it's a question bank plus a review course that you do, or just change the way you're studying, or maybe doing even more just general questions. If you think you learn in audio format, you're always welcome to listen to our pod. We've got hundreds of free episodes.
Absolutely.
If you want hundreds of, other episodes, we have the premium pod. You're always welcome to listen to that. But by no means are we saying you have to subscribe to our podcast to pass the boards or anything like that. I would just, I want to mainly just reassure folks that, it can be discouraging, but just keep at it. Just add to what you're using to study. Don't use the same method that you used the first time.
Mix it up.
Mix it up. That's what you need to do.
And more time sometimes doesn't always mean better studying.
There you go. Yeah. Do you have any other tips?
Yeah, I totally agree. I think coming out with an outline, and we've had some requests from some subscribers, which we'll deal with individually, but we appreciate people reaching out to us. But mix it up for sure. If unfortunately you didn't pass that first time or second time. And the big thing is, I would say actually the biggest takeaway here is don't let it affect your care. Obviously, not passing a board exam doesn't mean you're a bad doctor. And that sounds really silly to say that, but people think that and internalize it because we're very type A people. So don't ever let that get to you. It's just an unfortunate hurdle that is part of, qualifying for a very important specialty.
And I think the real elephant in the room is the fact that the folks who took boards this time, it was the COVID time. Right, let's be
the
real.
Educational structure was pretty bad.
Education we know suffered
pretty bad
during COVID. That is a full stop. We know that.
We're publishing studies about it.
We're publishing studies about it. We know that. So don't make it. Just understand that when you came into it, there's a reason why. As an
game
aggregate,
was stacked against you.
Yeah, exactly. As an aggregate, we didn't see that, and that's why it's just so important to get that clinical care. And that's why I always tell residents and other folks, you really learn best by just seeing patients and things like that. And during COVID, frankly, there were lots of lulls of not seeing folks and not having in-person, education going on, right? So,
for sure,
it was tough, but I will say, getting another year in of clinical practice is going to help. You're going to realize how much of a better physician you are just by getting reps, by seeing folks, and then adding to your toolkit of what you're using to study, I think is going to be really important. And don't hesitate to reach out to us on Twitter or individually as well. We're happy to, field questions and things like that. We've had subscribers in the past years who haven't passed and they've subscribed to the premium pod, and we've helped them out in terms of like, hey,
Absolutely.
this is the layout, how you should be studying and whatnot. Don't hesitate to reach
Right.
out to us. Yeah.
Yeah, definitely reach out to us, and there'll be some more info coming in the
Yeah.
next several weeks, especially if we ramp up preparation for the ITE after
Yeah.
the holidays.
Yeah.
And we'll be here for you as we always are.
Yeah, and I will tell we have residencies who use us for residents who struggle with the ITE,
Yeah.
and we've had really good success with those residents who struggle on the ITE, and there really is a direct correlation between how often those residents are listening and doing reps, right, on the pod. I'm sure they're doing other things too, like question banks and other things. So I'm not going to just say it's just the pod, but it is, a lot of it is really just reps. Reps, especially like questions and what you're studying, and you're gonna be fine. I think that's the last thing I'm gonna say is you're gonna be fine. That residency class, who took the boards, this past year, that was, I would argue, one of the most competitive years for EM as well. All right, see you, Briggs. Happy Thanksgiving.
See you later,
everyone.
buddy.
Bye.